Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Cancer immunotherapy has really revolutionized the field of oncology, significantly improving outcomes in cancers that previously had very little effective treatments. At the same time, these drugs are like double-edged swords because they also contribute to the development of immune-related adverse events. In rheumatology, our treatments are mostly based on taming an overactive immune system, whereas these new drugs work by releasing the brakes and letting the immune system go wild, with the hopes that the immune system will now recognize and kill the cancer. Not surprisingly, patients often develop immune-related adverse events, or IRAEs, often mimicking diseases that we normally treat, such as inflammatory arthritis, Sjogren's syndrome, and inflammatory myopathies. We've invited Dr. Laura Cappelli to explore the complex world of immune-related adverse events, including how they occur, the most common IRAEs, monitoring strategies for patients receiving immunotherapy, risk factors for developing IRAEs, and the use of DMARDs and biologics to treat these diseases. The importance of a multidisciplinary team to manage these patients will also be discussed. Dr. Laura Cappelli is an associate professor of medicine and oncology at the Johns Hopkins University School of Medicine in the Division of Rheumatology, and she's a faculty member of the Johns Hopkins Arthritis Center. She's really been at Hopkins since forever, having attended medical school, residency, and doing her fellowship in rheumatology. Dr. Cappelli also obtained a master's in health science and clinical investigation. Guess where? At the Johns Hopkins Bloomberg School of Public Health. Her primary research focus is rheumatologic adverse effects of cancer immunotherapy, which is what we'll be discussing with her today. Dr. Cappelli also co-chairs the immune-related toxicity team at Johns Hopkins, and she leads the rheumatic immune-related adverse events program in the Division of Rheumatology. Enjoy. Laura, welcome to the show.
Thanks so much for having me, John.
So how did you become interested in studying immune-related adverse events of immune therapy for cancer?
That is a question that I get asked a lot because it's not your average rheumatology interest. And it's also a question that people who know a little bit about me think they know the answer to, but they don't actually know the real story. So
bring it out.
So background, my husband is an oncologist, actually. And so people assume that is why I got interested in taking care of patients who had complications of cancer immunotherapy. But that is not actually it at all, although he does prove helpful when I need to ask some questions about what's going on from the oncology standpoint. But actually, this started in 2015. I was on vacation in Ireland, I think it was, and I got an email from my mentor, Bing Bingham, who's the head of the Arthritis Center here at Johns Hopkins. And he said, I'm getting several requests for patients that are having new joint symptoms who are on these immune checkpoint inhibitors for cancer. Is this something you're interested in? If so, will you see them with me in clinic? And at this time, I was a fellow. I was finishing my second year of fellowship, going into my last year of fellowship, my third year. And I said, sure, that sounds interesting. I don't really know much about this, but let's see these patients and see if we can figure it out. And from there, it just sort of took off. We told the oncologist we were happy to see these patients and think about them together and how we should best treat them and evaluate them. And from there, the clinical led into the clinical research and other research. And here we are almost 9 years later, where this has been a major component of my career.
Amazing. And it's so interesting how things like that happen, that it was never planned and you had this opportunity and you went for it, and you've certainly done really, really well. So you mentioned this started, your interest started in 2015. So tell me a little bit about these new immune therapy drugs that are being used in the cancer realm, and why we as rheumatologists have to be concerned about their adverse events.
So the first the first immune checkpoint inhibitor therapy that was approved back in 2011 is a drug called ipilimumab, and it works by blocking CTLA-4, which is one of the checkpoint molecules that prevents overactivation of T cells. And so I think if we had been, if we had a crystal ball or we'd been thinking more about our pathophysiology, we would have realized what was coming for us, because CTLA-4, we all should know as rheumatologists, because we like to use the agonist of CTLA-4, abatacept, to treat a variety of conditions in our adults and children. So this was the first drug that was approved, and that was back in 2011, but it was one drug. It was only for metastatic melanoma, which is not that common. And I think that the signal really wasn't breaking through. Then in 2014, the drugs were approved that targeted PD-1, the anti-PD-1 drugs, nivolumab and pembrolizumab. And PD-1 is a different checkpoint molecule that is involved in, again, regulating T cell responses, but more in the periphery rather than centrally. And the expression of PD-1 and its ligand PD-L1 is a bit broader and on different cell types than CTLA-4. And so those drugs being approved really opened the floodgates, and then many more agents were approved targeting PD-1 and PD-L1. And these agents alone, not even in combination, we found were causing a variety of rheumatic immune-related adverse events, or IRAEs, as we sometimes abbreviate them, but the most common being inflammatory arthritis. And so the way I like to simplify it, because we always have to simplify immunology, at least I do for my brain, is that you're doing something that is, if not diametrically opposite, fairly opposite of what we're trying to do in autoimmune disease. In autoimmune disease, we need more of our immune checkpoints. We need to regulate our dysregulated T cell and downstream responses. But when you have a cancer that you want the immune system to recognize and then help to eliminate, you want to take off those brakes from the immune system. So you want to block those checkpoints. And so oncologists and rheumatologists are doing opposite things to this part of the immune system, which is involved in regulation.
Got it. And, that idea of empowering your own immune system to fight cancer is certainly novel and really interesting. And it's sort of, again, diametrically opposed to what was done before with chemotherapy, where you just try to kill everything, including your immune system. And here you're sort of leveraging your immune system to try to target the cancer. And you have these immune-related adverse events, I guess, as a side effect.
Yeah. And when patients do not have immune-related adverse events, to your point, these drugs are really well tolerated. They're much better tolerated than chemotherapy because they're not causing this widespread cell death of rapidly replicating cells. So people aren't losing their hair. People aren't having the GI symptoms, the nausea that you can have with chemotherapy. So, until they have these immune-related adverse events, they're usually cruising along fairly well as compared to chemo.
Got it. So how common is the development of IRAEs in patients that are receiving them for cancer therapy? Does it happen in everybody, half the people, or a small percentage?
It depends on the regimen. So if you're using the drugs as monotherapy, so one at a time, the ones targeting PD-1 or PD-L1, it's maybe about 20%, 25% of patients will get an immune-related adverse event. In combination therapy, where you give both blockade to PD-1 and CTLA-4, the rates are much higher, much greater than 50%, greater than 60% in some studies. So it can be a very common phenomenon, and patients can have more than one immune-related adverse event during their course, because though in rheumatology we focus on certain IRAEs, they can really affect almost any organ system in the body.
Got it. Can you tell me a little bit about sort of what are the most common ones in general and the ones that are most commonly seen sort of by rheumatologists or, affecting the systems that we take care of?
Yeah, I like to think about the common ones and the most severe ones. I think it dates back to residency, where you didn't want to miss the common things, but you also didn't want to miss the things that were going to kill your patient. So those...
So it's a good thing to know, to
Yes.
learn about.
the extremes. So common things, cutaneous IRAEs, so various kinds of skin rashes are very common. And they're usually mild and self-limited, but there are a variety of more severe skin IRAEs. Patients can get a psoriaform rash that looks just like psoriasis. So we might, as rheumatologists, see patients in that context. Endocrine IRAEs are very common also, particularly thyroid disease. It's standard of care to check a TSH with every cycle of immune checkpoint inhibitor therapy because thyroid disease is so common. And patients can require then lifelong or extended thyroid replacement therapy after that. Some of the things that we don't see in rheumatology as much, but can be quite severe, are colitis, inflammation of the colon, pneumonitis, encephalitis. Those can all be very serious IRAEs. So those are some that we don't see as much as rheumatologists. For rheumatology, the most common thing we see is inflammatory arthritis, and then probably followed by a Sicca syndrome, which has some similarities to Sjogren's. But the thing we should be most concerned about is myositis, particularly because it can have overlap with myocarditis and myasthenia gravis when it presents as an IRAE, and there's really high morbidity and mortality when you have that triad, the triple M, as they call it.
Which is myositis, myasthenia gravis, and myocarditis?
Yes, exactly.
Okay. So how should patients that are receiving these drugs be monitored? What do oncologists typically do to look for these things? You mentioned checking a TSH for thyroid disease because it's so common. Do they usually get, is it just on the history, on the physical exam, or do they get associated lab work?
I think the most important thing that oncologists or any other physicians who are seeing these patients can do is to educate patients about the variety of IRAEs that can take place, and just to empower them if they're having new symptoms to talk about the new symptoms and reach out to their providers and discuss. Because besides the thyroid and some other endocrine IRAEs, most of them are a clinical diagnosis, so made by history and physical exam. For things like colitis, colonoscopy or sigmoidoscopy can be helpful with biopsies. Cutaneous IRAEs also sometimes get skin biopsies to evaluate further, or imaging studies in some cases. But it ultimately comes back to being a good internist and listening to the patient when they have new symptoms that could be a consequence of their immune checkpoint inhibitor therapy.
Got it. So in a patient that's complaining to joint pain, how do they typically present in the rheumatology clinic? What does this immune-related adverse event, arthritis, present like?
So they are certainly presenting earlier now and less severely than in the early days. So this has kind of evolved. In the early days of doing this, it wasn't a well-known immune-related adverse event. And by inflammatory arthritis, I mean. And so patients would be having joint pain, stiffness, swelling, and oncologists wouldn't realize that it's related to the therapy necessarily. And so patients would come in not able to walk because they had such severe knee arthritis. When I started doing this, I mean, you'd easily get 60 cc's out of each knee if you tap the, I still see that patient in clinic that I got, 60 to 75 cc's out of each knee the first time
Wow.
he hobbled in to clinic. So yeah, it's wild. But, I think there were multiple things going on. There was a lack of recognition on the oncology side, a lack of education about inflammatory arthritis as an IRAE, and patients are motivated to stay on their cancer treatment. And that's still an issue. And so patients will minimize their symptoms often. And unless directly asked or examined for relevant findings, they might not necessarily tell you exactly what's going on. Totally natural reaction to try to stay on the therapy if the therapy is helping their cancer.
Absolutely. So do they present in any specific pattern? You mentioned knee arthritis. Is that particularly common, or do they present like RA or?
There's a ton of clinical heterogeneity that we're very interested in understanding better. Where is the heterogeneity coming in? So some people will present with small joint polyarthritis, MCPs, PIPs, wrists, looks like rheumatoid arthritis if you didn't know anything else about the situation. A lot of patients will present with lower extremity oligoarthritis, knees and ankles in particular. The knee is the most common joint to be involved if you look at patterns of joint involvement, but pretty much any joint can be involved. Axial involvement is more rare in terms of sacroiliitis or lumbar cervical spine inflammation, but it has been reported. And in addition to synovitis, there is a lot of tenosynovitis, enthesitis, some dactylitis that patients can have. And I think what I am trying to get away from, and I think others as well, are putting the categories of traditional autoimmune disease on these IRAEs, because we know that they're not the same thing. We know the pathogenesis here. We know it better than we know our traditional autoimmune diseases, which are always multifactorial. And so it is natural to try to anchor to what we know in terms of clinical phenotype. But I think to move beyond that and to really understand these IRAEs, we sort of need to take them as new inflammatory diseases that need their own classification.
That's interesting. Is there a differential diagnosis of inflammatory arthritis that is not related to checkpoint inhibitors in patients receiving these therapies? Should we be thinking about other things that could be mimicking immune-related adverse events presenting as an autoimmune arthritis?
Definitely, we should always be thinking of the wider differential. Some things that are important to consider are, one, crystalline arthritis, both because crystalline arthritis is common, but also because with the endocrine abnormalities that can occur with checkpoint inhibitor therapy, that can be associated with pseudo-gout development. So, if you can aspirate a joint, and it's not always so easy that you're going to get 60 cc's out of the joint, but if you can, and ruling out pseudo-gout and gout as potential causes, that's an important thing to do, especially in patients who are looking highly inflamed and have very tender joints. Another thing to consider in patients that are coming with joint pain and stiffness is whether it's actually inflammatory arthritis or it's related to osteoarthritis. So there have been a lot of reports of worsening osteoarthritis pain and stiffness with immune checkpoint inhibitor therapy. So these are folks who had OA before their cancer treatment started and have more symptoms in the joints that had known OA. And some people call this activated osteoarthritis. I don't exactly know what that means, but there
it's been turned on,
charged up. So, and some people like that term. So, that's don't more power to them. But it is definitely true. And I think oncologists have been noticing this even longer than we have because they've been seeing these patients, that patients with OA will have more joint pain. And so that's when imaging can be helpful, ultrasound or MRI, to see if there's actually, synovitis, tenosynovitis, et cetera.
Got it. Okay. And do the patients with like small joint arthritis, are they seropositive, or are most people developing these sort of side effect or immune related arthritis seronegative?
Most of them are seronegative. So less than 10% are seropositive for rheumatoid factor or anti-CCP. A positive ANA is maybe 20% of the time if you count low titer as well as high titer. So not very helpful either. And there is some evidence that in a subset of patients who are seropositive, they had those autoantibodies before the immune checkpoint inhibitor therapy, and it's sort of unleashed, an inflammatory arthritis where maybe they had already the propensity for that ahead of time. And so that is a subgroup of patients, but I think definitely not the majority. The majority are seronegative.
I remember a while back that patients that had pre-existing autoimmune diseases, there was some hesitancy about using these immunotherapies for cancer. Are they at increased risk of developing these immune-related adverse events? Are they, is the patient with RA or Sjogren's syndrome still getting these immune therapies for if they develop malignancy?
Well, they should still be getting them if they have gone to a rheumatologist who has some experience. They should be telling the oncologist to go and how to proceed with the best treatment plan for the cancer. So certainly patients, there are two issues, right? There's an issue of flare of the underlying autoimmune disease, and there's an issue of de novo IRAEs. And it's not clear that the patients with pre-existing autoimmune disease are at any higher risk of de novo IRAEs than the general population. If you look at the rates from the studies that are out there, it's not anything wildly different. And so they need to be counseled just as any patient would be counseled about these other IRAEs like colitis, skin rashes, endocrine IRAEs. For flares of autoimmune disease, they can happen. We don't have great numbers, maybe 30 to 50% of the time, usually managed with steroids, often don't need to stop the immune checkpoint inhibitor therapy. And so there's not a single patient who's come through Johns Hopkins, would see myself or my colleagues, where we've said, no way, don't give them immune checkpoint inhibitor therapy. So even, my colleague, Dr. Ami Shah, seeing scleroderma patients who have interstitial lung disease, they monitor them every 3 months with PFTs and CT scans, but they don't say, don't try it.
Got it. Are there any known risk factors for development of immune-related adverse events of these types of immunotherapies?
There seem to be some associations of particular IRAEs with particular tumor types. So vitiligo, more common with melanoma because the shared antigen, that one we actually understand. But some other things like pneumonitis, I think more common in lung cancer. You can also sort of understand why that is, but also more common in renal cell than in melanoma. And why is that? We don't have a great explanation. In prior studies of rheumatic IRAEs, Dr. Jeff Sparks' group out of the Brigham, they've seen with melanoma and GU malignancies, more rheum IRAEs and inflammatory arthritis. So potentially the tumor type matters. It doesn't seem to be related to sex, male or female sex of the patient. Both seem affected pretty equally, which is a little bit different, right, than many of our autoimmune diseases, which show an increase in men or women. And in terms of genetics, I feel like we're only scratching the surface. There have been some HLA associations, like for insulin-dependent diabetes, some of the same associations you see with type 1 diabetes are there for getting insulin-dependent diabetes as an IRAE. But we don't really have the full picture yet of who's at most risk and what all the risk factors are.
Hmm. Interesting. Something to study. And I find it fascinating that it's the cancer type that predicts IRAEs in these patients and not because they're getting the same therapy, whether, often whether it's lung cancer or, some other type of malignancy.
Yeah. And I think it's not for all IRAEs and it's not with all malignancies. Certainly anybody's at risk regardless of their tumor type. But it is interesting to think about how related or not related the anti-tumor immune response is versus these other anti-self immune responses that are causing the IRAEs. And it's certainly, when you think about treatment, it would be easier to treat them if those are unrelated, right? If those are decoupled, because you want to preserve the anti-tumor response. You don't want these inflammatory responses against the colon or the joints or whatever it is.
And I guess another thing that you mentioned is that combination therapy seems to increase the risk of these IRAEs, like a CTLA-4 and a PD-1 or PD-L1.
Yes, absolutely. I think those patients receive a lot of counseling about what to look out for because it's assumed they're probably going to have an immune-related adverse event at some point in their course.
Got it. So let's switch over and talk a little bit about management. So you mentioned that patients that are receiving these therapies should be counseled and they should be aware to look out for morning stiffness or swollen joint or all of these other side effects. So how should these patients be managed in the clinic and who should be part of their management?
It is truly a case where it has to be a multidisciplinary discussion and the oncologist has to be involved in the decision-making with the rheumatologist and the patient. It's also complicated because there aren't clinical trials to guide management. So all of the guidance is either expert opinion or based on observational studies. And so it's important, I think, to tell the patient what we know and what we don't know, to give our recommendations, but then also to check with the oncologist about what their thoughts are, what they're planning to do with the cancer therapy going forward. It might be a good time, the patient might be doing really well, and it might be a good time for them to hold the immune checkpoint inhibitor therapy while we treat the immune-related adverse event. Or they might be early in their immune checkpoint inhibitor course, and the oncologist might say, I'd love to at least get a few more months in of therapy. What can we do concurrently to manage symptoms while they're still getting their immune checkpoint inhibitor therapy? So there are a lot of different scenarios that can take place depending on the patient's tumor type, their stage, where they are in their checkpoint inhibitor course.
So practically, how does it work at Hopkins? Is there a dedicated clinic that these patients get referred to? And how do you communicate with the oncologist to make these decisions about stopping their cancer drugs or treating through them?
So we have adopted a model of having this immune-related toxicity team. We started it in 2017. Dr. Drushka Naidu, who was a lung cancer oncologist here until she moved back to Ireland, and I started this. And it was basically the idea to connect all of the specialists who had interest or knowledge in IRAEs, be it the pulmonologist, the dermatologist, myself as a rheumatologist, with oncologists who were treating with immunotherapy. And we started a sort of listserv and a process where people could submit queries to try to get questions answered for patients in the hospital or try to set up consults for patients as outpatients in the clinic. There was a lot of debate in the beginning, should we have a clinic within oncology where these patients are seen? And other centers have adopted that model. Like UCSF has one or two nurse practitioners who see patients urgently with immune-related adverse events and sort of triage them or get them in touch with specialists if they are needed. Ultimately, because their IRAEs are so diverse and you need so many specialists, getting them physically to the cancer center at any regular interval was almost impossible. And, we're equipped in our own clinic to do our own thing, right? Like in rheumatology, we have the equipment to aspirate or inject a joint. GI knows how to schedule their colonoscopy or flex take the quickest out of their clinic. And so we decided to keep the specialists in their clinic, but keep them connected through this immune-related toxicity team. It's still evolving, a work in progress. We're working on e-consults as a possible adjunct to the inpatient appointments, something that we're working on now. But yeah, we're always refining the imperfect system that we have currently.
Got it. So it sounds like it takes a village because of the wide variety of organs that can be affected by these immune-related adverse events. So that's fascinating. So let's talk about treatment. So you have your patient with 60 cc's of fluid aspirated from each knee. How do you think about treating their immune-related adverse event? I'm always, concerned primarily, are you going to, certainly if you stop their immunotherapies, is the cancer going to come back? Or are you going to make their immunotherapy less effective by providing treatment for their IRAEs?
Yeah, and that is a very legitimate concern. And it's the main concern the patients have also when they come into clinic and want to talk to you about, understandably. So the first line of therapy is usually corticosteroids if it's not just one or two joints involved, or you could do intra-articular steroid injections, or they're too severe for NSAIDs or contraindications. And steroid dosing, I don't think we understand what is the best way to deliver steroids to these patients in terms of, should we start low and go up if they need it, if they don't respond, or start higher and try to taper quickly for symptom control, and what leads to a lower steroid dose ultimately. If patients either don't respond to steroids or are unable to taper off for inflammatory arthritis, then we'll move on to either DMARDs or biologics. And so methotrexate, TNF inhibitors, IL-6 receptor inhibitors are typically the most common used. And certainly, there have been a lot of concerns about how is this affecting the anti-tumor response. It is likely that the thing that matters most is the timing. So if patients can be off of immunosuppression in the beginning of their immune checkpoint inhibitor therapy, that seems better. So even patients with pre-existing autoimmune disease. But if they can avoid in the early days steroids or other immunosuppression, that is good. And then treating IRAEs later with steroids or short-term immunosuppression has not been shown to affect outcomes in several kinds of cancers, like melanoma and lung cancer.
Okay, so giving the immunotherapy a chance to work sort of initially without intervening seems to be a good idea. And I guess, if somebody has, a little bit of joint pain, a little bit of joint swelling, are there discussions that you have with the oncologist about, should we do a little bit of prednisone, or, should we just do NSAIDs? Is that the type of discussion that you commonly have?
Right. Should we do prednisone, NSAIDs if they have mild symptoms? Should we start, something like Plaquenil that we're not as concerned is interfering with things? I'll give you an example of a tough situation from clinic yesterday. Literally, is today Thursday? Yeah, literally yesterday. So I had a patient who developed an inflammatory arthritis who has melanoma and developed an inflammatory arthritis from nivolumab and relatlimab, which is is the new combination therapy. Hasn't received any since July, but still has persistent inflammatory arthritis, which is something we can talk about, those who develop chronic problems. But anyway, unfortunately, the melanoma came back. She had a lymph node biopsy that proved that. And so we needed to figure out what we're going to do before she starts ipilimumab and nivolumab next week. And so she had inflammatory arthritis, synovitis in several joints, but not so severe that she couldn't babysit her granddaughter and do the things that she wanted to do. So we basically just said, NSAIDs, intra-articular steroids for the large joints. We'll try to get you as many doses of your new regimen as possible. But then, the minute that you start having more severe symptoms, will swoop in and either give you a course of prednisone or start a TNF inhibitor at that time. So it's not, I think that's probably the hardest thing for the rheumatologist is like looking at swollen joints and not doing anything.
Yeah.
Right? That's not our inclination. That's not, we're treating to target, we're going for remission and low disease activity. And that's what I'm doing for the rest of my patients who have RA and psoriatic arthritis and all these things. But that is not always the right thing to do in these situations. And so we have to accept that symptoms might not be perfectly controlled and that's probably what's best for the cancer treatment.
Interesting. I mean, I'm always concerned tumor necrosis factor inhibitors, right? So these are, in theory, TNF is something that kills cancer, and then you're inhibiting that. So is there data that some of these patients that you give TNF inhibitors, their cancers, do they do worse?
So like all of immunology, how many times will we say this on the podcast? Like all of immunology is complicated. So there are actually times when blocking TNF is beneficial for tumor killing. And there are studies ongoing of immune checkpoint inhibitors given in combination with TNF inhibitors to boost their efficacy rather than the other way around. Same with IL-6. There's actually some pretty good data that high levels of IL-6 are detrimental for response to immune checkpoint inhibitors, and maybe blocking it is a good thing. And the jury's still out on all of that. But the concern is certainly shared by us and the oncologists that this would potentially be the case. And it's really mixed data. I mean, in terms of short-term use for colitis, there doesn't seem to be an issue. We did a multi-center observational study that was led by Dr. Ann Bass from Hospital for Special Surgery, 6 sites where we looked at inflammatory arthritis patients who developed it from checkpoint inhibitors and who were treated with TNF inhibitors, IL-6 receptor inhibitors, and methotrexate. And the TNF inhibitors worked better than the methotrexate, but there was a shorter time to tumor progression in those with TNF inhibitors. Now, this is an observational study, so there are many things that could be affecting that. We didn't take into account all the steroid dosing or the different tumor types, those sorts of things. But certainly, we need better studies to really understand what is the risk of longer-term TNF inhibitor treatment for these patients.
Interesting. So it sounds like in deciding what type of treatment to provide your patients, it's both about their disease severity, where in their cancer treatment it is, whether or not the medication, could be their immune therapy could be stopped or not. And then also thinking a little bit about prognosis, where how severe is their cancer and what's the potential for your DMARDs to affect their cancer progression. Sounds like a lot of things to juggle, and
Yes.
And I'm glad that it's done in conjunction with their oncologists and other physicians. Do patients that have one IRAE also are more likely to develop others? Like if they have inflammatory arthritis, are they more likely to develop colitis or thyroid disease?
So I think of our cohort of patients with inflammatory arthritis, maybe 30 or 40% of them have another IRAE more often before than after the inflammatory arthritis, but they can have them after as well. And if they have more than one IRAE at the same time, trying to figure out, is there a treatment that would help more than one thing is certainly what we try to do. If it's colitis and arthritis, it's easy. TNF inhibitors work well for both of those. And so that would be the route that we go. If it's arthritis and pneumonitis, it's a little more complicated in terms of what you would use for steroid-sparing agent that's going to work for both of those things. So that it definitely is something we think about. It's not all the patients, but it happens.
Mm-hmm. And you hinted at earlier in the discussion whether patients that develop IRAEs like inflammatory arthritis, are they doomed to have inflammatory arthritis forever? Like, do you change their immune system so that, this is the new reality? Or is it temporary for some of them?
So it is a little bit of both. From our data, at least 50% of patients who have inflammatory arthritis and are seen, severe enough to be referred to rheumatology will have persistent symptoms at least 6 months after their checkpoint inhibitor is stopped. We picked 6 months because that's the point where, in terms of these checkpoint inhibitors are monoclonal antibodies, and so they should be mostly out of the system at 6 months. We have patients who've had symptoms for 8 or 9 years after they stopped their checkpoint inhibitor therapy. And it's great because they're alive to have those symptoms. But the oncologists are making more business for us, which, right? Like we've got workforce issues. I don't know that we can accommodate. No, but patients always want to know that question, is this going to resolve once I stop the immune checkpoint inhibitor? And we also don't understand whether arthritis is unique. There are certainly reports of things like colitis and pneumonitis being chronic after checkpoint inhibitor therapy, but not to as high a percentage as inflammatory arthritis, at least in terms of what's published. So that's a thing that we definitely need to understand, what's happening in inflammatory arthritis that is causing a subset of patients to have chronic symptoms versus other IRAEs.
And do you think we've learned anything about autoimmune diseases and rheumatic diseases from patients that develop IRAEs with immunotherapies? Like, is there anything that we can glean from them, either about the pathophysiology or potential other treatment options?
Yeah, I think it's all still a work in progress, but we definitely, that was one of my hopes in getting into this field in the first place, was what can we take back to our traditional autoimmune diseases in terms of pathogenesis and risk factors and all of that. So I think it's ongoing study, but understanding the heterogeneity in inflammatory arthritis, for example, may be helpful to that, and why some people, the people who go on to look more like they have a spondyloarthritis, how are they different from other patients in terms of their genetics or other pre-existing risk factors. So I think we're definitely not ready for prime time yet in that area, but there's a lot of work trying to understand how we can learn from these patients and bring it back to our other rheumatic diseases.
Yeah, and I remember listening, I think it was last year's Convergence, about a PD-1 drug for the treatment of rheumatoid arthritis.
Yeah.
So instead of releasing the brakes, is putting the brakes back on. And it's fascinating to think about things like that in light of the immunotherapy for cancer.
Yeah, absolutely. And thinking about, what are the potential risks of those drugs, and, who to best, like what disease states we should best use those drugs in. Definitely something that I have been asked about by before. So I think there are definitely ways we can leverage what we're learning from IRAEs to the rest of rheumatic disease. And I'll be interested to see, as more of the phase 2 for the other PD-1 agonists, other compounds are going into phase 2, phase 3 probably soon for the Lilly product. And we'll see how well they work and what the side effect profiles are.
Amazing. And are there other things that you're still wondering about? Any questions that remain in terms of these immune-related adverse events of immunotherapy? Anything you're actively studying or wish to study?
Oh gosh. Too many things. Too many things to study. Who wants to give me some more funding to study that? One thing I'm interested in and working on right now with a radiology collaborator is how pre-existing perturbations of the joint environment might impact risk for inflammatory arthritis. I think that's more widely applicable to myositis to Thicca syndrome, PMR, what are these pre-existing risk factors that we can define in inflammatory arthritis? One I'm interested in is pre-existing osteoarthritis as a risk factor, for example. So I think that's really important to guide us in terms of monitoring these patients and intervening early in IRAEs. The biggest question that we've talked about several times is the safety of using immunosuppression for treating these patients, and the best model of steroid use, the best model of DMARD biologic use. And so doing clinical trials to define that in a more robust way is of great interest to the IRAE community.
Any thought about changing IRAE to IRAEs? So just to make it easier on the tongue?
I mean, we can try. We can try to make it happen. You're going to try to make IRAE happen. I
IRAEs, yes.
IRAEs.
Let's make it happen.
IRAEs all day.
Laura, you and I go back over a decade. You remember, we started together in the Fellows in Training subcommittee of the ACR. Really was like a decade ago. And it's been amazing to see your progress from a fellow to now a world-renowned expert in IRAEs.
I'm blushing. You can't see it on the podcast, but I'm blushing.
And it's been amazing to see you through that. And I wonder, how did you make it happen? How do you attribute your success in becoming like the expert, at least in my mind and in a lot of other people's minds, in IRAEs?
Well, you can't do any of it alone. So I give a ton of credit to Bing Bingham and Ami Shah, who are my mentors and believed that this was an important area and encouraged me to get back up every time the funding didn't work out in the beginning, or I was having difficulty, navigating my collaborations with oncology or whatever it was. So I feel like everybody's origin story goes back to the people and the mentors who supported them. So that was a huge thing. And I feel very lucky to have found such great people. And also Anthony Rosen, who gave me the great advice that I'll share to anyone starting a new program, research or clinical. When I was getting, discouraged in the beginning, he said, and I'm not going to do a South African accent because we don't need that. But he said, Laura, do you know about entropy? I said, of course I knew about entropy. I took like AP physics, He's like, well, entropy, the universe tends toward chaos. You are trying to put order into a space that is disordered. And what do you need to overcome entropy? I said, energy. He said, that's right, energy. He's like, and luckily you've got a lot of it. So that was back before I had 2 kids and everything else. And I did have a lot of energy. And so that, I think finding people who support you and share your vision and putting the energy into it, even when there are roadblocks, because there always will be roadblocks when you're doing something that's different and people aren't going to understand. And God bless all the funding agencies, and we couldn't do the work without them. But, sometimes things are too new and there's not enough preliminary data, and there's not enough science to sort of convince our existing funding structure to fund what you want to do. And so, finding philanthropy or we got funding in the beginning, investigator-initiated observational study from industry to help what we were doing. So I think just looking outside of the traditional sources when you have a new idea and continuing to just go.
Amazing. And any other words of advice in terms of not only, getting funded and pursuing your passion, but finding the niche, right? That, this was new back, when you started. Nobody was doing this. So for fellows that are now training or newly graduated, how would you recommend they find their niche and sort of make a little space for them, within this very busy field?
I think people are very concerned with that of how are you going to be unique and how are you going to stand out? And I think that will come as your interests develop. And it is probably more important to have a mentor who has a great track record of mentoring and success, and to start working in their area, and then, learning enough to figure out what is your area. And it might be that you are going to gain expertise with a new technique or technology that your mentors don't have, or you are going to, bring about, study a different aspect of the disease from your mentors, but use the same tool or the same data set or whatever it is. So it doesn't have to be, I wouldn't tell everybody, go find a new rheumatic disease. The only way you're going to be successful.
You have to, Vexus, right? You're going to be the new Vexus person.
Right. If you don't discover the new Vexus, you're out of here. So it doesn't have to be that, but it does have to be something that you're interested in enough to put in the energy and to think about it enough to see where the gaps are and where you can add to the field. So yes, no, you don't have to pick something that doesn't exist now to be your interest. There's lots of ways to go about it. But it's hard. And there are things that, I think about my friends and colleagues who went sort of the more traditional path of getting involved in their mentors' research and sort of branching out from there, and the way that I did it. And the way that I did it was definitely more painful in the beginning, but I think gives me way more options in the end. So there's good and bad to it all.
Yeah, and I guess you need energy to fight entropy. I don't think we've ever discussed physics here in this podcast, and I'm really glad you brought it up.
Oh, yeah.
But Laura, thank you so much for your time. This has been amazing. It's been amazing to see you become who you are now, and I can't wait to see what's next for the next decade or two or 5. Who knows?
Who knows?
And we'd love to have you back on the podcast to provide us with updates of everything you've done.
Well, thank you so much for having me. And, I'll have the audience know that you were the reason originally that I joined, formerly Twitter, now X, because, and I think that is a special skill of yours, seeing what's coming in terms of the tech and the media. So this is a perfect spot for you. So glad to be on with you hosting this show. It's great.
Awesome, Laura. Thanks so much for the kind words. And I hope you keep that energy up and keep on advancing the fields.
Take care.
Well, there you have it. With the help of a multidisciplinary team, you're now ready to start treating these patients in your clinic. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep fighting entropy. And of course, stay healthy.